provided by fibroblasts, and this is provided by proliferation of these fibroblasts. So fibroblast proliferation is also one of the prerequisites which is required for successful healing of a diabetic foot ulcer. But if you see the products which are available in the market, they would either satisfy one or at the most two of these prerequisites which are required for healing of the ulcer. So if we talk about the growth factors which are available in the market, they only promote the fibroblast proliferation. Povidone iodine solutions are only providing an antibacterial action. Carboxylic iodine also only antibacterial or an antimicrobial action. Nanocrystalline silvers, they provide two actions, that is earth moist environment and antibacterial action. Normal saline only provides an earth moist environment. Antibiotics, of course, as we know, that it only provides an antibacterial action. And if we have to talk about alginates, alginates only have the earth moist environment or keeping the wound moist. That is what is the action which is present with the current modalities which are available for healing of diabetic foot ulcers. So if we have to talk about the modalities, they would either control the infection, or they would promote wound healing, or they would provide an earth moist environment for the wound to heal. There is not a single product which is available in the market which provides all the three, and that is where we come in. Diperoxochloric acid is a new chemical entity which has been developed by Cytotools and Centaur. These are the two global companies which have co-launched this product. We have done the in vitro studies in Germany. The preclinical studies, that is the animal studies, were conducted in GLP accredited labs in Germany as well as in India. We have already completed phase 2 and phase 3 randomized controlled trials in India. We have recently also completed the active PMS or the diperoxochloric acid in India. Phase 2 randomized controlled trial is already done in Europe, and phase 3 trial is ongoing in Europe. So if I have to talk about what is Voxi, the generic name of Voxi is diperoxochloric acid. It is categorized as a new chemical entity and is patented around the world. The chemical structure is on the screen. If we have to talk about physical properties of this solution, it is a clear, colorless, odorless solution. Storage conditions are room temperature. Many of the products which are available in the market, especially the growth factors, they have to be stored at 2 to 8 degrees. This product can be stored at 2 to 8 degrees, it can be stored at 25 degrees, it can be stored at 30 degrees. We also have stability studies going up to 40 degrees. So this is a completely thermostable product. The indications for it, which it is approved, is diabetic neuropathic ulcers of the skin and subcutaneous tissue. Now, if I have to talk about the timelines, the invention of this particular product happened in 2003. Subsequently, we did the in vitro studies, phase 2 studies, phase 3 studies, and the final approval we received in 2019. The very purpose of showing you these slides and the dates is because I want to tell you that we have not taken any shortcuts, we have not cut any corners, and we have done proper research on this particular molecule. It has taken us nearly about 18 years for this molecule to come into the market right from its inception, and we have done it honestly. Now, when I have to talk about the mechanism of action of diperoxochloric acid is shortened as DPOCL. When it comes in contact with the ulcer, it basically releases nascent oxygen and nascent chloride. The nascent oxygen is responsible for promotion of MRC5 fibroblasts, which cause complete wound closure, and the nascent chloride exhibits an antimicrobial action which controls infection. And as DPOCL or diperoxochloric acid is also a solution, when it is on the wound, it also provides an earth moist environment. So it basically has all the three prerequisites which are required for successful healing of a diabetic foot ulcer. Now, what is the evidence for the same? We have conducted many in vitro studies followed by animal studies and then human clinical trials. We will start with the in vitro studies where the mechanism of action is proven. We have done this cell culture studies on fibroblasts to study the fibroblast proliferating activity. We have taken somewhere around cell lines of 100 fibroblasts. We exposed these fibroblasts to DPOCL, that is diperoxochloric acid, and after 24 hours we saw that the count from 100 had gone up to 1300. So 13-fold increase in fibroblast cells was what was seen. So this was a macroscopic study, but what actually happens at wound site, we further went ahead and did research on the same, and we found out that in the supernatant which was present on the cell line studies, when we evaluated that supernatant, we found out that there are about 4 enzymes which are increased because of introduction of voxel to the cell line. First one is VEGF, that is vascular endothelial growth factor. As the name suggests, it is responsible for the vascularization of the wound so that the wound heals faster. Second is macrophage colony stimulating factor, or MCSF. It basically increases the immune response locally at the wound site. Third was transforming growth factor beta 1, which basically is going to influence the collagen deposition at the wound site. And the third and the final one was interleukin 6 or IL-6, which is responsible for fibroblast proliferation. So the oxygen moiety which is released at the wound site stimulates these 4 enzymes at the wound site, which is responsible for increased fibroblast activity, and finally you have complete closure because of the fibroblast coming at the wound site. The second mechanism of action is because of the chlorine moiety or the nascent chloride. Initially what in vitro studies we did was with Escherichia coli, Pseudomonas aeruginosa and Staphylococcus aureus, and we saw that when we exposed these 3 microorganisms which are responsible for about 80% of diabetic foot ulcer infections, we saw that the count decreases within 2 hours of exposure of DPOCL to these microorganisms, and there was absolutely no decrease which was seen when they were exposed to the general medium or normal saline. So it shows that DPOCL is responsible for release of chloride at the site, nascent chloride at the site, which is responsible for the antibacterial action. So as the slide says, about 80% of the microorganisms, what about the remaining 20%? So we did further studies on the escape pathogens, which are responsible for the other 20% of infections of DFU, and we found out that there is decrease of nearly about 99%, 80 to 99% for most of the microorganisms which are going to infect diabetic foot ulcer. So we have done studies on Proteus, we have done studies on Providentia whitgeri, we have done studies on Enterobacter, Enterococcus, methicillin resistant Staphylococcus aureus, all the notorious microorganisms which are responsible for causing infections in a diabetic foot ulcer. And as we can see, the antibacterial activity is against all the escape pathogens. Coming to preclinical studies, we have done extensive preclinical studies before we actually introduced voxel in human clinical trials. We have done acute studies, subacute studies, chronic studies, all the organ toxicity related studies. Importantly, we have done the mutagenicity studies. Mutagenicity studies are not available with majority of the growth factors. We have done 2 types of mutagenicity studies. First one is the ME studies and micronucleus studies, which basically show that even at a dose of 1,000 times the dose of human, when mutagenicity was studied, this dose also did not have any mutagenic potential. Anything which proliferates any cells in the body, they have known to have mutagenic potential. They may cause cancers in the future. So we wanted to study whether this product can have such kind of an adverse effect in the future or not. Eventually, we got permission to do phase 2 and phase 3 clinical studies. We did both these studies were randomized controlled trials, double-blinded studies. Phase 2 studies were done at 4 centers, 85 patients, 42 patients were receiving DPOCL, and 43 patients were receiving active control. Phase 3 studies were done at 12 centers, 289 patients, 139 patients received DPOCL, and 150 patients received active control medication. The test medication was DPOCL or diperoxychloric acid solution, and the reference medication was isotonic normal saline solution, which was considered to be an active control because normal saline is used in the treatment of diabetic foot ulcers. This was common in both the studies. Both the studies had a study duration of 10 weeks. The DFU enrollment criteria for the phase 2 study was Wagner scale grade 1, grade 2, and for phase 3 it was stage 1A, 1B and 2A of the University of Texas Wound classification system. The primary efficacy variables in both the studies was percentage of patients achieving complete wound closure. Secondary efficacy variables was how much time it took for that complete wound closure to happen, percentage of wound surface area reduction at each visit, and total wound evaluation score was also studied at each visit. Safety variables, vital signs, of course, blood glucose levels at each visit. End of the study, clinical lab investigations were performed where kidney function tests or renal function tests and liver function tests were performed. And standard care which was provided was offloading, debridement of wounds wherever it was necessary. Debridement was only allowed at the start of the study. Glycemic control, very, very important. No topical antimicrobials were allowed in the clinical trial. Only systemic antimicrobials were allowed wherever it was required. Now talking about the studies or the result, in the Voxil group, I'm combining both the results of phase 2 and phase 3 studies. Total population which received Voxil was 181 patients, out of which 137 patients achieved complete wound closure, which is about 75.69%. Whereas in the active control medications of the 193 patients, 121 patients achieved complete wound closure, which is about 62.69%. And the results, when you compare, the results were statistically significant. Now it is not only the number of patients achieving complete wound closure which is higher, it is also how much time it took for the complete wound closure to happen. So number of days which were required for complete wound closure, total about, on an average 42 days were required with Voxil, whereas 56 days were required for the active control medication. So faster wound healing by about 2 weeks is what is another advantage with Voxil. Treatment failures was about 6% in Voxil arm, about 23% which was there in the active control arm. And if we have to talk about the use of systemic antimicrobials, whether it is parenteral or oral, in the Voxil arm, not a single patient received systemic antibiotics after 1 week of starting the Voxil therapy. Whereas in the active control medications, many of the patients received systemic antibiotics up to 3 weeks of starting the therapy. So this is very, very important because these patients are diabetics. Diabetic patients, as we know, the kidney function is already decreased. And when we are going to use systemic antimicrobials, most of the systemic antimicrobials are nephrotoxic, and nephrotoxicity is going to further decrease the kidney function in these patients. So if we can limit the number of days where we are going to use antimicrobials, systemic antimicrobials in DFU patients, that is also very, very important. Now if I have to talk about week-wise visit, again at every week, at every visit, more number of patients who were in the DPOCL group had wound surface area reduction, which was better as compared to that with the active control medication. These are a few images from the clinical trials. This is a patient with an ulcer size of 7.5 centimeters square. Ulcer was present for 8 weeks, that is 2 months prior to enrollment in the trial. The ulcer was not healing. We debrided the ulcer and then we started with the Voxil therapy, and the ulcer healed in just 5 weeks. So 8 weeks before the ulcer was not healing, and we started DPOCL, and the ulcer healed in just 5 weeks. This is another ulcer, 10.45 centimeters square. The ulcer was present for 6 weeks before the start of Voxil therapy, and when we started the Voxil therapy, the ulcer healed in just 5 weeks. Another patient, 5.4 centimeters square, ulcer healed in just 4 weeks. This is another ulcer on the dorsum of the foot, 4.8 centimeters square. Ulcer was present for about 3 months before starting with the DPOCL therapy, and when we started with DPOCL, the ulcer healed in just 1 month. This is a classic neuropathic ulcer which is there. This was a young patient, 46-year-old. The ulcer was not healing for about 14 weeks. Somebody had told the patient that if the ulcer does not heal in more than 4 weeks after this, we will have to go in for an amputation. Though the ulcer was clean, this is a debrided image of the ulcer. This was present for 14 weeks before the start of voxel therapy, and after starting the voxel therapy, the ulcer healed in just 4 weeks. This is another patient, 7.2 centimeters square. Ulcer was present for 9 weeks before start of DPOCL, and when we started with DPOCL treatment, the ulcer healed in just 7 weeks. This is another challenging case. This was a case from Manipur in the eastern part of the country. Patient had come to Guwahati because there was no tertiary care center which was present at that particular place. And you can already appreciate that there are already 2 toes which are amputated here, and at the base of the amputation you have a big ulcer which was present. Now the patient was afraid that he will lose further, he would have to go in for a metatarsal kind of an amputation, and he would lose his foot eventually. Again, we started with voxel therapy. The ulcer was present for 15 weeks before we started with the therapy, and the ulcer healed in just 5 weeks after starting with voxel. Another patient, 8.32 centimeters square, where the ulcer healed in just 4 weeks. Another patient where the ulcer is present on the ball of the foot. This was a deep ulcer which was present for about 7 weeks before start of DPOCL, and the ulcer healed in just 6 weeks after start of DPOCL. Another deep ulcer, 9.6 centimeters square, where the ulcer healed in just 4 weeks. Here, the patient had already lost a toe about 10 years back. There was an ulcer which was quite deep, 18 centimeters square was what was the size of the ulcer. Here, ulcer was present for more than 10 weeks. When we started with voxel, the ulcer healed in just 7 weeks. So if I have to draw the conclusions of the 2 clinical trials, the randomized controlled trials, the complete wound closure was achieved in more than 75% of the patients who were receiving voxel, and this was a statistically significant result when compared to the active control medication. There was a rapid reduction in the wound surface area as compared with the active control medication. Wound infection was controlled from the first application itself, and not a single patient in the voxel arm received systemic antibiotics after 1 week of therapy. There was no drug-related adverse events which were present at the wound site, whether it is burning, stinging, itching, irritation, or maceration at wound site. It is completely non-toxic to the wound. There were no drug or drug dressing interactions noted throughout the trial, and the ulcers very importantly healed without any keloid formation. The phase 3 clinical trial was published in June 2022 in the International Journal of Lower Extremity Wounds, which is a high impact factor journal. And this is the results of phase 3 clinical trial, which was published as original article in IJLEW, June 2022. Some interesting cases. This was a very chronic ulcer, 57-year-old patient. The ulcer was present for 3 years. The ulcer was not healing. We debrided the ulcer and we started with voxel therapy along with systemic antimicrobials, and the ulcer healed in just 3 weeks. So 3 years the ulcer was not healing, and when we started with the therapy, it healed in just 3 weeks. Another patient where this particular patient was an organ failure patient where we had CKD as well as congestive heart disease in this particular patient, and when we started with voxel therapy, the ulcer healed in just 4 weeks. This was a type 1 diabetic patient, very young patient, 27-year-old patient. This patient had undergone series of amputations in the past, and as we can see here, this is a below knee amputation stuff which is there, and there was a big ulcer which was present here at below knee amputation site. And we of course did debridement extensively. We started with IV antibiotics, and when we started with voxel, the ulcer healed in just 5 weeks of starting voxel therapy. This is a 62-year-old patient where we had to do a lot of debridement. Though the ulcer initially looked very, very small, but when we debrided and we removed all the necrotic tissue, all the slough, the ulcer became very, very big, and we started with voxel therapy, and the ulcer healed in just 5 weeks. 80-year-old patient, we have a patient who is now 89 years old also, with whom we have tried voxel, and we have had good results with with respect to the healing of the ulcer. So in this patient, 4 weeks the ulcer healed completely. Now talking about the phase 4 clinical trials, product was launched with the condition that we have to do a phase 4 clinical trial. That is what is the regular regulation. After phase 3, you get an approval and then you have to do a phase 4 clinical trial. So we did this active post-marketing study where if we have about 252 patients, wherein 224 patients were enrolled in the study, and the results are now available for these 224 patients. Now here we have gone a little ahead. We have also included patients of University of Texas classification wound 2B. So we have 1A, 1B, 2A, which was already there in phase 3 clinical trials, but we have now 2B also begun in this particular active post-marketing study. And out of the 180 patients who successfully completed the clinical trial, 134 plus 40, that is 148 patients achieved complete wound closure. That, if you have to amount it into percentage, it is 82.22%. So in phase 3, the results were about 75%, which increased to about 82% when we did the phase 4 study. And if we have to talk about the wound size reduction at each visit, we started with an average of about 7.16, and at every visit, as you can see, there is a decrease in the wound surface area which is there. And even in patients where the ulcers do not have complete wound closure, that is the remaining 20% of the patients where complete wound closure was not seen, there also you can see that there is the wound surface area has reduced, and maybe in another 2 or 3 weeks it would completely close. So if I have to talk about the number of days which it took for the complete wound closure, as we can see at every visit and at every week, more and more number of patients achieve complete wound closure. So these are a few photographs from the phase 4 study. As you can appreciate here, many of the pictures, the ulcers are quite huge, quite big. And we had also allowed for skin grafting in some of the patients where we did not want the ulcers to heal by primary intention. So these are a few cases, a few photographs from the phase 4 study, especially if you can appreciate case 5 and case 4, wherein the ulcer, the size of the ulcer is quite huge, wherein the healing has happened. These are deeper ulcers from the phase 4 study, wherein we had to do a lot of debridement, we had to remove a lot of the necrotic tissue, and there was a lot of tissue loss which was there. And when we had to start voxel therapy, the ulcers were quite deep. We had to, dress these ulcers. We had to put, we had to do a packing gauze kind of a dressing in these particular patients. Few more cases from phase 4. Here also you can see that the ulcer size is quite huge. Again, few more cases where the ulcer size is huge, and when we have started voxel therapy and the ulcer has healed within about 4 or maybe 5 weeks of starting with voxel therapy. These are some smaller ulcers, smaller neuropathic ulcers, very difficult to treat, present on the weight-bearing areas of the foot. Offloading many a times is not possible in these patients, but still we started with voxel therapy and we have got results in these patients. Again, similar kind of smaller ulcers present on the weight-bearing areas of the foot. Lastly, I would like to present just 2 more clinical studies which are ongoing. These are phase 3 studies. The first one we are going to do for venous leg ulcer. We want to expand the indication from diabetic foot ulcers. Till now we have done extensive studies in diabetic foot ulcers, but do we have results in venous leg ulcers? We wanted to study that, and we have planned this phase 3 study, which has already been started, and we have completed about 80% of this study, venous leg ulcers. And as you can appreciate here, few photographs here, you can see the classical signs of venous leg ulcers, and wherein voxel was used. And these are initial results, of course. The final results are not yet compiled. I think by Jan or February of 2026, we should finish this study, wherein I can present the complete data. So these are few more cases from the venous leg ulcers. Initial results are quite promising. That is what I can tell you. And the second phase 2 study which we are going, phase 3 study which we are doing is on pressure ulcers or bed sores as they are called, classically called as. These ulcers are quite huge. As you can appreciate here, most of the ulcers are on the buttocks or on the back. Ulcers are quite huge. Some of the ulcers are deep, and this also study we have started, and this study is completed about 30 or 40%. Initial results are quite promising. I think by July, July of 2026, we should finish this study as well. So apart from that, we have planned another study, phase 3 study, which we have submitted to the Indian regulatory authorities for approval. The approval is yet pending. That is for the mixed arterial and venous leg ulcers, or MAULU as they are classically called as. Talking about the dosage, administration of Voxil is once a day. So the dressing is going to be done once a day. The approved indication is diabetic foot ulcers of skin and subcutaneous tissue in both, that is infected as well as non-infected ulcers. And if you have to talk about the dosage, if the wound is going to be covered completely by a gauze of 5 by 5 centimeters, which is provided in the back, then the dose which is going to be used of Voxil is 3.5 ml. If you put 3.5 ml on a gauze of 5.5 centimeters, the gauze becomes first piece, so that it does not cause maceration on the wound. You have to use it for a long time. Similarly, if you have to use 2 gauze pieces and the total size is going to be 5 by 10 centimeters, the dose is double, that is 3.5 into 2, which is 7 ml. And if you have to use 4 gauze pieces of 5 by 5 centimeters, which are provided in the pack, the dose is going to be 3.5 ml into 4, which is 14 ml. So for each gauze which is provided in the pack, the dose is 3.5 ml. The dropper and everything is provided in the pack. So with this, I finish with my presentation, and thank you once again for giving me the opportunity to speak today, and I would be happy to take questions if there are any. Thank you so much. I would like to thank the chairpersons as well. Thank you.
Thank you, Dr. Kiran, for your wonderful and detailed deliberation on management of diabetic foot ulcers and diabetic ulcers. Though I don't have with such encouraging results, though I don't have any personal experience of using Voxil, but here we have plastic surgeons and maybe many more surgeons who can share this their own experience also. And the session is open for discussion. Any questions from the audience, please?
A very interesting talk, Dr. Kiran. Actually, I must compliment you for very
Except mine is not working.
I have a doubt that is working. Sir, please keep it. I can feel it louder. Yeah, I must compliment you for these wonderful studies that you have conducted. I just have one concern and one query. You were mentioning the dosage to be OD.
Yeah.
And I was going through your slides that you showed regarding 2 bacteria, Providencia reticuli and Proteus mirabilis. In 4 hours, the concentration of bacteria drops to 80% only. Whereas for others, it was around 99%.
19 to 99.
So should we change our dosage patterns as and when required, or is it like that?
A very nice question. Of course, though we recommend that the dose is going to be once daily, but of course, you being the clinicians, you see the patient and you actually know what the patient requires. If you feel that the patient is having a wound which is oozing a lot, the dressing is getting soaked, there is a lot of pus which is coming from the wound, then of course you can do multiple dressings in a day. Of course, whatever the patient requires is what you have to give. Our recommendation is once a day, but I am sure that you would be the best judges of using it. Once you start using it, you will yourself come to know that how it is best to be used. So that's how.
Any role in non-diabetic ulcers?
Yeah, we are currently doing two studies in venous leg ulcers and in pressure ulcers, as I have shown, and the results have been good. Of course, they were being used off-labelly in these indications, but we wanted to provide you with hard data, and that's why we are doing a proper phase 3 studies with regulatory approval. And those studies will be submitted to the regulatory authorities. We will get an approval for these indications, and then we can promote in these indications also. But off-labelly they have been used.
Thank you for this excellent presentation. Most of the slides which you have shown, we have seen patients much more ulcers which are much more in size, and we have been treating them regularly. No doubt, first initially with various dressings, including your product, we have been using it for last couple of years with very encouraging results. And ultimately, I think once the wound is free from any infection, then simple grafting, if it takes well, it is going to make a lot of difference. A wound which will otherwise take a month, 2 months, the graft takes it is just a matter of days, maybe 10 days or 15 days, it gets healed well. But no doubt there are some chronic wounds which are not fit for grafting. With chronic granulation tissue, there is a lot of fibrosis where we need some molecules like the one which we have discussed, and we have been using it. Definitely in some situations it does help. It makes the wound optimal for definitive procedure in the form of grafting or some local flap, especially pressure ulcers, where initial treatment in order to make it fit for the definitive procedure, we do use various chemicals because there has been a tremendous change in the last 2 decades in the management of wounds. This is one among the molecules which we have used, and it does definitely help. To cut short the course of the disease, we have to use some other methods of reconstruction in the form of a graft, a local graft.
Of course.
Yeah, so,
Of course. So very rightly said, sir. We are also we have also got excellent results where the wound becomes graft ready, so that it can receive the graft, and the graft is taken up. So even if you want to graft the wound, then also we can use Voxel initially to make the wound graft ready, and then you can graft. So that's how it is.
Actually, this compound causes decrease in the bioburden on the bioburden and the biofilm which is there present in the wound. That's one of the important causes of non-healing occurrence.
Exactly.
And that is very important factor in making this wound chronic. That's what is the theme of our so that it decreases that bioburden and decreases the amount of biofilm, and it makes wound graftable or amenable to any other modality of management. Or it can heal, a small wound can heal of itself, by itself, as you have shown. Thank you.
One final question. You have studied safety and efficacy. So, what about cost?
Cost, I suppose, my sales.
Per square centimeter of surface area of the beach.
Right. So what I can tell you is, if the wound is small and it is going to be covered by a 5 by 5 centimeter gauze, then in one pack can be used up to 8 days. 8 days. And the cost the cost is how much?
10 days dressing, 150 rupees per day dressing.
For 150 rupees per day dressing.
Or 5 hours. 5 hours.
Some of the wounds in your study takes few weeks, 5 to 7 weeks.
Yeah. Exactly.
And multiple dressings if they are done in difficult wounds, the cost is going to be a little.
Yeah. That's But if we have to compare the cost of our therapy versus that of growth factors which are available in the market, the growth factors are much more expensive. At the same time, they have to be stored at temperature which you cannot go above or you cannot go below. And in case if that happens, then the efficacy is lost. That is what is true. So here,
Any studies done, comparable studies?
comparable studies are not there as yet, but we plan to do a comparative study in the future. Right now, we want to expand the indications. We are at the initial phase where we want to go from diabetic foot ulcers to other indications, not diabetic indications. Once that is done, then we would also have an head-to-head kind of studies which we do with the other modalities.
Thank you, Dr. Kiran. It was a wonderful session.
Thank you so much, sir. Thank you. Thank you.
So, next session.
Thank you, sir. That was a wonderful talk. May I now request Professor Mufti Mahmood, sir, former Head Department of General and Minimal Access Surgery, GMC Srinagar, to kindly come on the stage for felicitation, sir. I request our speaker, Dr. Mayuresh Kiran, to please come on the stage and receive your memento, sir. I request Professor Ijaz Ahmed Rasid, sir, Head Department of General Surgery, SKIMS Medical College, to please come on the stage. I request Dr. Nazir Ahmed Salru, sir, former Professor and Head Department of General Surgery, GMC Srinagar, to please come on the stage. I request Dr. Arshad Rashid, sir, Associate Professor, Department of Minimal Access and General Surgery, GMC Srinagar, to please come. Thank you so much, sir. Thank you. To pay tribute to our great teachers and mentors, I request Professor Iqbal Salim Meek, sir, Head Department of Minimal Access and General Surgery, Government Medical College, Srinagar, to please come on the stage and share his thoughts. Thank you.
Good afternoon, everybody. In Government Medical College, Srinagar, Department of Minimal Access and General Surgery, we always believe that we must honor our seniors, we must respect them, and that respect does not end if they are not with us. So today's program is basically dedicated to 3 of our teachers who have left us, who were heading the departments and who had significant contributions both in my personal life as well as with the departments. Our first is Professor Ashif Hussain, the legendary CVTS surgeon of our valley, the person who shaped me. I can tell you, I was very rough, I was very gruff, but he was the person who made sure that, no, I teach him the basics, I teach him the values that human life is above everything, and I pay my tribute to him, and I am very thankful to Dr. Ifra and Dr. Yasir, who came here with just one phone call. They understood that, no, we want to share something. Then we had one of the most dynamic persons. Once I entered as postgraduate, and Professor Mufti Mahmood was I think I was the house surgeon and Professor Mufti Mahmood was the, yes. And here, this guy, he was wonderful, Professor Firzada Abdul Rashid. He was so good, so nice, always thinking about the patients, and his contributions to both the department and other colleagues. It was so immense, and I pay my tribute to him. I hope God gives him peace. He is at peace wherever he is. Then the person whom I have idolized right from the start of my life. Now you will say why? My mother was dying. She was having GI bleed, and this is the time once you did not have endoscopes, you did not have CT scans, you did not have any gadgets, and 26 points of blood were transfused. Thankfully we have a large family, so we were not worried about the blood, but we were transfusing blood and she was getting GI bleed. And then Professor Nizar sir, he stood up and he operated her for 3 hours, and she survived 20 years after that. So he was a person, once I looked at him, I knew that I had to be a doctor, and when I entered the medical field, I understood that this is the path I have to choose. And how he handled the department, how down to earth he was, that was something that affected me also. Therefore, I request Dr. Hanif to say a few words and read some verses so that their peace is at soul. Dr. Hanif. Hanif sir, aye. I would request all of you to please stand up and be in silence for 2 minutes so that we give them a fitting tribute.
बिस्मिल्लाहिर्रहमानिर्रहीम। हमारी तरफ से डिपार्टेड सोल्स के लिए सूरतुल फातिहा माल इखलास। अल्लाहुम्मा सल्ली अला सय्यिदना मुहम्मदिन व अला आलि सय्यिदना मुहम्मदिन व असहाबि सय्यिदना मुहम्मदिन व बारिक वसल्लिम अलैहि। बिस्मिल्लाहिर्रहमानिर्रहीम। अल्हम्दुलिल्लाहि रब्बिल आलमीन अर्रहमानिर्रहीम मालिकि यौमिद्दीन इय्याका नअबुदु व इय्याका नस्तईन इहदिनस सिरातल मुस्तक़ीम सिरातल लज़ीना अनअमता अलैहिम गैरिल मग़ज़ूबि अलैहिम वलद्दाल्लीन। बिस्मिल्लाहिर्रहमानिर्रहीम। कुल हुवल्लाहु अहद अल्लाहुस समद लम यलिद व लम यूलद व लम यकुल लहु कुफुवन अहद। बिस्मिल्लाहिर्रहमानिर्रहीम। कुल अऊज़ु बिरब्बिल फलक मिन शर्रि मा खलक़ व मिन शर्रि गासिकिन इज़ा वक़ब व मिन शर्रि नफ़्फ़ासाति फिल उक़द व मिन शर्रि हासिदिन इज़ा हसद। बिस्मिल्लाहिर्रहमानिर्रहीम। कुल अऊज़ु बिरब्बिन नास मलिकिन नास इलाहिन नास मिन शर्रिल वस्वासिल खन्नास अल्लज़ी युवस्विसु फी सुदूरिन नास मिनल जिन्नति वन नास। रब्बना तक़ब्बल मिन्ना इन्नका अंतस समीउल अलीम। बिहुर्मति सवाब तकबीर अल्लाहु अकबर ला इलाहा इल्लल्लाह वल्लाहु अकबर अल्लाहु अकबर लिल्लाहिल हम्द। Thank you.
Thank you everybody for coming on this cold winter day and being part of our endeavor to pay tribute to our teachers. And thank you Dr. Arshad for being kind enough to be here. Please accept my deepest sympathies. Unfortunately, nobody is from these other of the Shields families here. Therefore, it was not possible to ask somebody to be here. Thank you once again.
Thank you, sir. Now I invite Organizing Secretary, Professor Dr. Mushtaq Ahmed Mir, sir, in charge, Head Division of Plastic Surgery and Burns, Department of Minimal Access and General Surgery, GMC Srinagar, to please share your thoughts, sir.
Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatan min lisani yafqahu qawli. Assalamu alaikum. Good evening to everybody. The respected head of the department, General and Minimal Access Surgery, Government Medical College, Srinagar, Professor Iqbal Salim Saab, Professor Ajaz Ahmad Rathir, Head of the Department, General and Minimal Access Surgery, Sikkims Medical College, ex-head of the Department of Surgery, GMC Srinagar, Professor Shafi Saab, Professor Mufti Mahmood Saab, Professor Salman Saab, other esteemed faculty members, postgraduates, and colleagues. It gives me immense pleasure to extend a warm welcome on behalf of Department of General and Minimal Access Surgery and the allied specialty of plastic surgery and burns to invite you to this unique surgical discourse which is entitled Wound Closure. This event is not just another academic session, it is a gathering of minds united by a shared passion, the pursuit of surgical excellence and commitment to healing. The very theme beyond closure, it reminds us that surgery is far more than sutures and scalpel. It is about understanding the intricate biology of healing, the science of tissue repair, and the strength of human resilience. We surgeons say that the operation does not end when the incision is closed. The true healing begins where the surgery ends. And it is at this phase the intricate interplay between biology, technology, and compassion comes into existence that defines the quality of the life the patient gets after a surgical procedure. The discourse has been thoughtfully designed to explore two challenging yet profoundly important topics: the chronic wounds and complex hernias. These conditions, they are very common and they test the skill, patience, and the expertise, not only of the surgeon, but also it is a test for the patient, for the family, as well as for the surgeon. Because we have seen some of these wounds like diabetic foot ulcers, pressure sores, chronic non-healing neuropathic wounds. They take weeks together to heal. It is really a challenging problem. In the last 1 or 2 decades, there have been a tremendous change and development in the management of wounds. By way of newer and newer molecules have come in the market in order to minimize the healing time, which ranges from weeks to months together. So there has been a tremendous change in the last 2 decades in the management of these chronic wounds in the form of various dressing materials like hydrogels and collagen-based dressings, silicone-based dressings, on few to mention. And more importantly, in the last decade, the management of these wounds has been revolutionized by negative pressure wound. It has been revolutionized the management of these wounds. Whether they are traumatic wounds or these are post-infective wounds, it has really revolutionized the management of these wounds. The wounds which would initially take months together, it optimizes these wounds in a span of 2 or 3 weeks for the definitive procedure in the form of a graft or a flap cover. So the classical apparatus which is used for this negative pressure wound therapy, it is a bit costly and it is not available everywhere. But in our institute, we have used the commonly available section. We are using that in patients, and we are managing different types of wounds, and it does really help in making these wounds fit for the different procedure in a quick span of time. And more importantly, the other topic which has been selected is the chronic and complex hernias. Normally, it is a simple hernia, it is a cakewalk for a surgeon, but if you have to really see the expertise of a surgeon, you should watch him operating upon a hernia. It really tells us how meticulous he is. If he's really, it tells us both about his anatomical knowledge of the pathology as well as the surgical expertise. If a surgeon does it nicely, so, but in case of complex and large ventral hernias, they are really a challenge, even for the most experienced surgeon. But in this aspect also, tremendous changes have taken place. New laparoscopic techniques have come into play, and every year a new technique is added. And more importantly, now Botox has been also used, especially in those cases which are recurrent and where there is loss of bone. Those are really challenged for an expert surgeon. But in our institute, our young surgeons, Professor Dr. Samoon, Dr. Irshad, and now Dr. Tahir, they have taken up the challenge. They are using these Botox and using their expertise to treat these complex entities. And more importantly, they have recently started using tissue compartment separation, which is a very challenging procedure. It really needs thorough knowledge of the anatomy of the abdominal wall. Only then one can do justice with it. Especially in those cases where there is loss of bone. Those are really challenging cases, but they have been doing a wonderful job in this in these cases. This all has been possible under the dynamic leadership of our organizing chairman, Professor Iqbal Siddiqui, who is really inspiring source of inspiration for all of us, and that continues to lay the academic standards of our department. I must thank my co-organizing secretaries, joint organizing secretaries, Dr. Karim Singh Khan, Dr. Hindi Mahmoudar, whose dedication and meticulous planning have made this evening possible. As has already been told by our head of the department, that today's program is based on 3 lectures which have been dedicated to ex-professors and head of the department of GMC Srinagar, Professor Pirzad Abdul-Rashid, Professor Mizgar Saab, and Professor Sayyid Ashif Hussain Lakshmani. I once again extend a very warm welcome to all of you. May this discourse strengthen our understanding of healing, both within the operating theatre and beyond it. Thank you, and I wish you great success, and I hope that you will enjoy it. Thank you very much.
Thank you so much, sir. For our second session, Professor Mohammed Shafi Mesgar Memorial Lecture on Negative Pressure Wound Therapy in Management of Chronic Wounds, I would like to invite our chairperson. I would like to invite Professor Mushtaq Chalhu, sir, Professor, Department of Minimal Access and General Surgery, Government Medical College, Srinagar, to kindly grace this session. I would like to invite Professor Dr. Zafar Salim Khande, sir, Professor, Department of Minimal Access and General Surgery, Government Medical College, Srinagar, to kindly grace this session.
Assalamu alaikum everybody. Exciting to see some of our senior colleagues and teachers in the audience. And it's a pleasure to say that this is dedicated to some of our wonderful teachers, and I'm one of their daughters. This reminds me of probably 94 or 93, when I landed in Ward 60. I had a dream to be a surgeon, and the late Professor Nisgar Saab was my advocate. I was a house surgeon. I still remember they shut me on the first day. Do you know what surgery is? I said, sir, I have come to learn surgery. They said, this is nothing beyond Misgiri and Zargiri. May Allah bless the school of Dargar Saab also. They were the pioneers that time. And nothing beyond what they did was surgery. And you see, every day exposes new things, but we must not say. This is what we say at this time, because we are currently in the fashion of laparoscopy. We say those open surgeons and start talking, what they were doing. So at that time, that was the dictum and that was the fashion of the day. So we should give regard. Tomorrow people will come with robotics. Wouldn't mean laparoscopic surgeons were not good. And that's the crux. So I would dedicate this session to them, and my blessings, my good wishes, and their soul rest in peace, and their hardships are here. I would also condone this time taken here. So before that, we must get into this time. We have one speaker in this, Dr. Mohsin Masood. He is a consultant Department of Plastic Surgery. He is going to talk on negative pressure wound therapy in the management of chronic wounds.
In the name of Allah, the most gracious, most merciful, esteemed organizing chairperson, distinguished guests, respected chairpersons, and my dear surgical colleagues. I am Dr. Mohsin Masood from the Department of Plastic Surgery, which is the division of Minimal Access and General Surgery, GMC Srinagar. It's a profound honor for me and a privilege for me to speak in front of this august gathering, which is comprising of distinguished surgeons of great caliber who have proven themselves not only at the national level but in many international fora. These are the people who have shaped our landscape of medical science and continue to do for the future also. So I thank the organizers for giving me an opportunity to speak in front of such brilliant minds. Dr. Mayuresh gave a pharmacological perspective of managing wounds. That's just a part how we visualize wounds. My presentation would be more a plastic surgeon's perspective, how we look at wounds, how we see chronic wounds. With the passage of time, the burden of chronic wounds is increasing. If we see, unfortunately, India has now become the diabetic capital of the world, and around 5% of India's total diabetic population is developing foot ulcers, and these are the patients which are landing up in amputation. The data is around 45,000 lower limb amputation annually. Whether we accept it or not, but the reality is that in our entire clinical practice, we would be exposed to this group of chronic wounds where diabetes is the underlying etiology. So the need of the hour is that we need to be prepared to deal with this group of wounds. The images in this presentation might be graphic, and some of our non-surgical colleagues or some of the non-surgical participants may find it disturbing. But this is the way it is. To start with the introduction to chronic wound, what are the challenges with chronic wounds? What actually makes a wound chronic? A chronic wound is not such a simplistic term. It's not just that the wound is slowly healing. It's a wound which is stalled in a self-perpetuating cycle. in a cycle of continuous inflammation, in a cycle of tissue destruction, and in a cycle of failure of repair. So there are some healing barriers in these wounds in the form of impaired perfusion, biofilm formation, chronic inflammation, and tissue palsy. If we go back to our pathological teaching, we will see that wound healing progresses through 4 principal stages: the stage of hemostasis, the stage of inflammation, proliferation, and remodeling. With each stage of wound healing having a specific group of cells. If we talk about hemostasis, platelets have a very important role to play. They are the initial cells which are recruited due to the formation of the plugs, and they stop the acute event in the form of bleeding. Then into the scene there come neutrophils, macrophages, which orchestrate the whole event. And in the late stages of inflammatory phase, significant role is played by lymphocytes. Coming to the proliferative stage, fibroblasts, and more specifically actin-containing fibroblasts, which are the myofibroblasts, this group of the cells decides the fate of proliferative stage. And finally, all wounds undergo the stage of remodeling, wherein there is a change in the type of collagen. Mostly it's changed from type 3 to type 1, and it takes weeks to months to years. But point of making you go through these steps of wound healing is to tell you that in chronic wounds, the wound is stalled. The wound gets stuck in the inflammatory phase. So there is a self-perpetuating cycle. The wound gets stalled, and these are the wounds which have a significant impact on the life of a patient. See, as clinicians, once we attend any patient, for us it's a daily routine, but there is a significant impact on their lives. I would like to discuss it case by case basis. These are the images of a young engineer from northern Kashmir. He is a machine learning enthusiast, an AI student with a very bright futuristic dreams. And his issue started with hallux valgus, and he visited an orthopedic colleague of ours, and a very beautiful surgery was done and hallux was corrected. But unfortunately, in the post-op period, the area where the dissection was done, that turned gangrenous, that area devascularized. So this patient had been healing, this patient had been dressing his wounds for over a period of 3 months with no outcome. What was at risk was the repair that was done by our ortho colleague, and at the same time, all of us should, if we do a sneak peek into the life of this young man, we would understand the psychological impact. My aim is to tell you that not only chronic wounds burden us financially, they have an emotional aspect also. A young enthusiastic engineer, bedridden for months. So you can imagine the burden is not just financial, there are significant psychosocial impacts also. This is another case. It's an employee of PWD department, and he had sustained a high tension electric burn. You can see the devastating extent of the injury in this patient, with the toes turned gangrenous and many of the toes being amputated, and again months and months of dressing. Can you imagine a sole bread earner of a family? He's staying at home, bedridden, and what these traditional dressing mechanisms are providing, they are not solving the problem at all. So not only an individual, but the whole family is affected by chronic wounds. Many a times in outdoor patient departments, we are not aware of these significant implications, but we should take a moment back and think how deep are the impacts of chronic wounds. To exemplify it further, I would like to describe these pictures of pressure ulcer. This was a case of grade 3 pressure ulcer affecting the ischial and the gluteal region. Again, 8 months this patient was bedridden with no respite, used almost everything available for healing. And what actually had happened that this wound had turned chronic and it was not coming out of the inflammatory phase. These are pictures of, these are two different cases. The first one, the picture on the left, is a young male who had sustained a road traffic accident. You can see the accident of injury, and you can see how gross contamination was present in the wound. Again, bedridden. This wound, this person was treating in a peripheral hospital for a period of 3 months with no improvement in the wound. This is another case. This is a traumatic injury in the lower forearm, and as you can appreciate from the pictures, there is a soft tissue loss. In addition to this, on examination, it was found that this patient had an underlying median nerve injury. So, virtually incapacitating this young male. My aim of showing the audience all these pictures is to make you go through the journey that chronic wounds have deep impact on the lives of patients. Now let's go and delve into the nitty-gritty of negative pressure wound therapy. I'll be providing you all the ingenious pictures, those cases which are present in our wards. And to begin with, what actually is negative pressure wound therapy? The commonly used term was VAC, but we prefer to call it negative pressure wound therapy because VAC is a trade name. It is the initial US company who had got the patent for this negative pressure technology. So the preferred terminology as this is an academic meet, the preferred terminology here today would be negative pressure wound therapy. VAC is just one of the companies which is providing this, and in fact VAC, that was the first pioneer company. The process of the commencement of negative pressure wound therapy started by two researchers. One of them was a plastic surgeon by the name of Dr. Argenta, and he had a co-researcher, Morivax. So these were the pioneers, and they found very promising results. And after that, 3M, which is a pharmacological company, they formed a patent for it, and they introduced it into the market. This is, if we talk about late 1970s. The idea of negative pressure wound therapy, as you can see in this sketch diagram, is that we are applying a contact dressing here. We are applying a contact dressing in direct proximity to the wound, and after that, we are covering it by an occlusive film. And above the occlusive film, we are applying negative pressure. So how actually negative pressure wound therapy works? It basically converts an open wound into a closed wound. And can it be used in closed wounds? Yes. There is a common practice of utilizing negative pressure wound therapy in surgical incisions also. This procedure is done in those cases where there are risk factors for wound extension or delayed wound healing. For example, in cases where patient is diabetic, patient is a smoker, he is a grade 3 or more, patient is obese. These are the risk factors wherein we can think of using negative pressure wound therapy even in closed wounds. So the message from this presentation today should be that this procedure is not alone utilized for open wounds, it's also used in case of closed wounds. If you see the global market share, this is a pie chart, it's a diagram from 2013. That's the period where there was a boom in negative pressure wound therapy utilization, and people started accepting it as one of the modality of treatment. And as you can appreciate, that it accounted for 16% of the global share. The current data is again 16%. So principally, it doesn't mean that negative pressure wound therapy and PWT hasn't progressed, but in turn it also means that it has stood the test of time. Even after more than a decade, the percentage global market share continues to be 16%. And another very important message from this slide is that we should view NPWT as a wound healing agent rather than as a sole modality of treatment. Because dealing with wounds, there is no one single shot answer to all the issues. We should visualize NPWT as one of the wound healing agents. Now, how these dressings are applied? There are 4 principal steps. Step 1 is that we debride and clean the wound, most commonly done with an isotonic solution. After that, the foam is cut and it is shaped in the form of a wound and is placed on the wound bed. Now, there are recently some changes because once initially NPWT was introduced, it was seen that patients started complaining of pain, and it was found that there was a need of an additional barrier. Now, what currently is being done is that underneath this foam, we are placing a wound contact layer. This wound contact layer is commonly available in our wards. We call it as burn mesh, and it is made up of woven fabric. So we clean the wound, that is the basic prerequisite before applying NPWT. We clean the wound, thoroughly debride it. After that, we place a wound contact layer, and that wound contact layer we cover it with sponge. This sponge has large pores, and after that it's contacted by an occlusive dressing, and then we make a perforation on it in this occlusive dressing and connect it to a negative pressure system. Mechanism of action, how actually NPWT works. It has been found that there are multiple mechanisms of action. The basic is that being a suction force, if we go into the physical aspects of it, it produces a strain at a macroscopic level, what we call as macro deformation. So you can imagine negative pressure being applied to a wound, and it will lead to the collapse. It will lead to collapse of wound. That process has been termed as micro deformation. But historical studies of these tissues have found that these deformations are also occurring at the cellular level. So you are applying a vac in this area, it is bringing the edges together. That is what we are seeing at the macro level. But at the micro level, there occur cellular deformations also. There occur cellular deformation, cellular proliferation has also been observed microscopically. This process has been termed as tension stress effect. That's one of the mechanisms how VAC works. Another very important thing and a very useful very useful method of action is the exudate management. See, why wounds turn chronic? Wounds turn chronic because they have there's a lot of negativity in a chronic wound. Negativity in the sense that it's filled with inhibitors of wound healing. It's filled with MMPs, matrix metalloproteinases. It's filled with cytokines. It's filled with those factors, those interleukins which are growth inhibiting, which are anti-proliferative. And plus there is a lot of exudative fluid. So by way of negative suction, it removes all those wound inhibitory substances. It removes all those exudates. And once all those exudates find their way through this tubing, what we observe is that the microcirculation of the wound improves. The nutrients, more and more nutrients move to the wound, and more waste products are removed from the wound. This is basic pathology. VAC works at the cellular level. Another important factor is that it has been found to reduce the bioburden of the wound, decrease the bacterial count. This is for open wounds. How vacuum mist closure or NPWT works in closed wounds. In closed surgical wounds, which I already told you that in patients who are at high risk for development of wound dehiscence or delayed wound healing, negative pressure wound therapy mechanism of action, it has been found that it reduces the tension in the wound, it reduces the edema of the wound, and leading to the quicker sealing of wound. Components, as already discussed, this is how we apply VAC in our ward. The initial material was the burn mesh. It's also termed as wound contact layer, and this is the sponge. In fact, this is an indigenous method which we have developed in our ward. It originated basically from skims. At the time whenever Health Department was present there, Professor Mushtaq and Dr. Harun Rashid, they were the pioneers. Once they saw that the original VAC system was not affordable to our populace, so they came up with this idea. It was, I think, more than a decade ago. They came up with this idea that all these materials we can arrange from our ward. This is how negative suction works. And the collapse is an indication, and we're connecting it to a wall-mounted suction. I'll be presenting the results at GMC Srinagar. This is again the same case, Alex Valdez series. This is how he came to us, and we put this patient on locally modified version. This is a very cheap version. All the things which are needed are available in our wards. A very bad wound, imagine 3 months. After that, we have placed this patient on VAC, and multiple VAC changes were being done. Our protocol is that for grossly infected wounds, we change VAC 2 to 3 times a week. Initially, recommendations are that it should be changed 3 days a week, and once the X rate becomes less and once the wound becomes better, then by clinical decision making, the frequency is changed and is brought down to, it transitions to 2 times a week. So we are applying VAC initially 3 times a week. As the wound clinically becomes better, then we decrease the frequency to twice a week. I think what VAC did in this patient was that we were contemplating a local flap on the foot. We basically, how we surgically treat these cases is that we Doppler a vessel here, which is the intermetatarsal perforator vessel. We transpose that tissue into this area. But those perforator flaps are technically very demanding and they are associated with a very high failure rate. You can imagine this person had lot of psychological trauma. Doing a procedure which entailed such high risk of loss, we didn't think that was feasible. So we chose this path, and ultimately you can see it served another purpose also. The hallux valgus correction, which you can appreciate by the straight great toe axis with the first metatarsal. So that good result which was achieved by our ortho colleague, that was preserved. There was a stage initially, once he reported, we were thinking of removing all those sutures and all the repair which was done at the tendon level, because the tendons were also exposed. And what VAC helped us in 2 ways: from avoiding doing a flap which was associated with a very high failure rate, and at the same time preserving the results of our ortho colleague. Coming to pressure ulcer series, again I told you about this patient, bedridden for 8 months, and dressings serving no purpose. Almost everything was dried. See how huge a difference VAC made. We were talking about macro level changes are occurring. You can see the wound dimensions, drastically wound dimensions removed. The wound appears to be cleaner. We were doing regular wound swab examination from the wound, and by the time the wound became closed, we were seeing the bioburden was also getting reduced. Biofilm was getting disintegrated, and ultimately you can appreciate in the last picture that the wound is closed. This is another pressure ulcer series. This patient was a middle-aged female. She was diabetic, and initially she reported to our emergency, and a diagnosis of carbuncle was made. And after that, because of being in one posture alone, she used to stay in supine position most of the times. This small carbuncle turned into a very large ulcer. And day by day this was increasing. She was brought up in emergency as sepsis on one occasion. So she was admitted, her sepsis was taken care of, and again, after doing all the debridements and clearing all the slough, she was put on NPWT. I think this picture better shows the extent. You can see this wound is almost closed. Another case, this is the electrical burn series. So the picture on the right is post-VAC application. This is just to tell you that this is not just one VAC, these are multiple NPWT applications. Again, the wall-mounted suction machine, which is available in almost all of our wards, that was utilized in this case. And we were initially thinking of doing a microscale flap in this, because post-debridement, many of the bony structures in the foot, they got exposed. So how VAC helped us in this case was that it prevented, it did the job which could have been otherwise we needed a very large microscale flap. And as you can understand, in resource constrained settings like ours, those things are difficult, and doing microscale flaps on 2 sides is also very tricky and demanding. Although in our department, all of us as plastic surgeons, we are trained to do microscale flaps, but clinical setting wherein the patient reports, that's also very vital. You can appreciate that a patient who needed a flap in the first place, because post-debridement, all the vital structures in the foot were exposed. How VAC helped? It saved this patient from a flap, and granulation tissue appeared, and then we grafted this patient. These are the intra-op pictures, post debridement. You can see the tendon, extensor pollicis proboscis tendon is exposed, and multiple negative pressure wound therapy applications led to the development of this granulation tissue, what we call ideal granulation tissue. It should be velvety, it should be red in color, it should be free of any shining material. The shine itself shows a biopolin presence in the wound. So once we were sure that there are no negative things in the wounds, the negativity has been removed from the wound. This wound was then graftable. A simple plastic surgical procedure in the form of separate thickness skin graft was done at the end. Now, what's the future of VAC? The future of VAC, a lot of research is going on currently. One of the deterrents of VAC, many patients found that these VAC machines are very heavy, they are costly. Now they are coming up with portable VAC machines, and these VAC machines, they will be connected with smartphones. There is research going on currently, and they are planning to incorporate artificial intelligence into it. So it would be a tailored portable VAC. Tailored in the sense that the VAC system would be prepared depending upon the patient's needs. Suppose if the surgeon or the treating physician feels that patient needs a 7 days VAC. Now you in future will be having a 7 days VAC machines which the patient could carry with him. And they are trying to reduce the size so as to make it portable. Another important, in the research aspect, another important thing that has been achieved is the use of the IVAC. What actually is IVAC is that in traditional VAC we only do the suction part of it. In NPWT or IVAC, what is actually being done, this is showing comparison with the traditional NPWT, and this is the IVAC. Here you can appreciate that only suctioning is being done, and here, in addition to suction, fluid is being instilled. There has been a lot of research which has been done on what type of fluid, and it has been found that simple normal saline, there is no statistical advantage has been found with using fancy antimicrobials. It has been found that if we use simple normal saline as an instillation fluid, that has been found to have equal result. Now how it actually works is that first VAC is applied, after that, after first session of VAC, this machine is switched off. We are switching off the negative force and the process of installation should start. The time for this normal saline remains within the wound, that is termed as dwell time. The average recommended dwell time is 6 to 20 minutes. 6 to 20 minutes fluid remains in the wound, and after that suctioning is applied. So it's like giving washes to the wound. Now how actually it helps? This basically, it protects or avoids daily dressings. In fact, it has been found that those centers where in NPWT has been used, the nursing staff, they are very happy. Their duty hours are free of potential dressing changes which otherwise they had to do. So that's one aspect, there is no need for frequent dressing. Another thing is that it leads to the cleansing of the wound. It has been observed that with every irrigation, it has been observed that the exudate that is coming, that is more clear. So a lot of it has been done on the research front. So my message as a plastic surgeon would be that negative pressure wound therapy, we should not restrict it to the Department of Plastic Surgery. In fact, all of our surgical colleagues can incorporate into their armamentarium. This is a very easy procedure. We can make use of all the things that are available. And I thank all of you for giving me this podium and allowing me to speak in front of such distinctions. Thank you.
I take this opportunity to welcome our Principal Dean, Professor Ifat Hassan Shah, and our ex-Principal and Dean, Professor Parvez, and all the ex-HODs, all the consultants, all the present HODs from different institutes to this place. And I'm really happy to see that the cold has not made you people weak and all the old bones are now really young. Thank you very much for coming here.
Thank you, Dr. Mohsin. This is an excellent, vibrant talk. From the pictures, we could see the effect of that. And in the very outset, I would say we should avoid getting wounded. When certain wounds happen, some of them are unseen, will leave a scar. But good WAC is a very interesting modality. I am thankful that I have been working with two of my very competent plastic surgeons who are trying to drag me to this specialty. I'm trying to withhold, but thankfully we have helped this Dr. Tahir Mukhtar. They do an excellent job in my unit, holding these, and I have also learned a bit from them. Thank you very much. If there are any questions, we can.
Nice talk, Dr. Mohsin, giving us a very good picture of the back. So what I found in this, it's like healing wound by secondary intention, isn't it?
Exactly.
Okay. For the smaller wounds, you don't graft them, you just try to do repeated backs and let them heal basically. But they are producing bad scars, isn't it?
Definitely.
And once you are using VAC for larger scars, it is producing a lot of exuberant granulation tissue, isn't it? Then you are putting a graft on it. Yeah, yeah.
In some of the pictures, as the audience could appreciate, that there was definitely exuberant granulation tissue, but in plastic surgery we term as proud flesh. And our protocol, our department protocol at Super Specialty Hospital GMC Srinagar is that we use low potency steroids for 3 to 5 days, and it has been observed that significantly that leads to the flattening of that granulation tissue, and the over exuberation is taken care of. And these wounds are then consequently managed by simple procedures like grafts. See, as far as the formation of scar is concerned, this discussion was about chronic wounds. This is a group of the patients, they have very limited options. So, sort of a compromise thing, we have to compromise on scar bottom, but it definitely leads to closure.
Dr. Mohsin, what has been your experience once a bone is exposed?
Yes.
Not the joint end. Then what do you do?
Sir, in cases where bone is exposed, we have applied VAC, both in the settings where there is a preserved periosteum and in those settings without preserved periosteum. Bones which are covered by periosteum, it has been seen that after a couple of applications of NPWT, whole area gets covered by granulation tissue. This being a vascularized tissue. It gets covered by granulation tissue and grafted. But the difficult situation arises once there are wounds which are devoid of periosteum. The protocol in those cases is that we do 1 centimeter distance, by the distance of 1 centimeter, we do multiple drills into the periosteum, into the bone, into the outer cortex of the bone. Our aim is to reach up to the bleeding point. What our idea is that the medullary blood supply, those vessels ingrow through these channels. That has been used in cranial diploid with success. We have done that. We have done by using an electrical handheld drill. 1 centimeter is the recommended distance, and yes, VAC has been utilized in exposed wound also.
Thank you very much, Dr. Mohsin.
Thank you so much.
Thank you, sir. I would like to invite Professor Dr. Munir Khan, sir, former head, Department of General and Minimal Access Surgery, Government Medical College, Srinagar, to please come on the stage for felicitation of our speaker and chairperson. I would like to invite our speaker, Dr. Mohsin Masood, sir, to please come on the stage and receive your memento. I would like to invite Professor Iqbal Salim, sir, to please come on the stage. would like to invite Professor Mushtaq Chalke sir to please come on the stage. I would like to invite Professor Dr. Zafar Salim Khande sir to please come on the stage. Thank you so much, sir. For our third session, Professor Ashik Hussain Naqshbandi Memorial Lecture on Management of Complex Ventral Wall Hernias, I would like to invite our chairperson. I would like to invite Professor Mohammed Shafi sir, former Head Department of General and Minimal Access Surgery, Government Medical College, Srinagar, to kindly grace this session. Sir, please. I would like to invite Professor Ijaz Ahmed Malik sir, Head Department of General and Minimal Invasive Surgery, Skin SORA, to please grace the session. Thank you, sir. I would like to invite Professor Nazir Ahmed Wani sir, Head Department of General Surgery, GMC Anantnag, to please grace the session.
It's indeed, good evening all. It's indeed a good time here to spend with the stalwarts, the old teachers from GMC, the place where from we have our products. I would request our co-chairman to introduce the next speaker for this session.
The next speaker is, before I will speak about the next speaker, I remember when I joined GMC Srinagar as postgraduate student, I was posted in Dr. Zargar Saab unit, and Dr. Ashik Saab was my registrar. And we had a very cordial relation. He was always helpful, and I really remember him very much. That he will be, every time we call him, he will be he'll be helping hand, and he will be teaching us very nicely. So I really remember him very much. I hope Allah Ta'ala will in Jannat Firdaus, inshallah. Now I will speak about the speaker, Dr. Hamid Samoon, Associate Professor, Department of General Surgery, Active in General Surgery Institute.
Respected Principal and Dean, Government Medical College, Srinagar, Professor Ifat Hasan Shah, esteemed Chairperson, our senior teachers, ex-faculty members of the Government Medical College, Srinagar, faculty members from various medical colleges of the UT of J&K, guests, and my dear students. Good evening to all of you. Today, I am in front of you here to speak about the management of complex ventral hernias.
I'm Dr. Gulamit Samu. I'm working as associate professor in the Department of Minimal Access and General Surgery, GMC Srinagar. So I bring you greetings from the department. So coming back to the topic of complex ventral hernias. So as surgeons, we all know that incisional hernias are a common complication after any laparotomy. So lot of patients who undergo laparotomy, they develop incisional hernias. But the beauty is that most of these incisional hernias, they are simple and they can be tackled very nicely by almost every person. But few hernias are challenging for the surgeon, and these challenging cases are called as complex ventral hernias. So if you go for the definition of complex ventral hernias, the ventral hernias whose size is around more than 10 centimeters with loss of domain. Loss of domain means when most of the contents of the abdomen lie outside the abdominal cavity for most of the time, they are defined as loss of domain hernias. Then patients having comorbidities along with the hernia, like chronic cardiopulmonary diseases or any other comorbidity, they again come under complex ventral hernias. Then patients who have already undergone repairs for these hernias one time or multiple times in the past, they again come under the category of complex ventral hernias. Then sometimes when we have operated upon a patient, when we have done a repair, they present with different challenges like fistulas, mesh infections, exposed mesh. So next time when these patients are operated, they pose a definite challenge, and these again are categorized as complex ventral hernias. So now, why are complex ventral hernias so challenging? Why are we talking about them? There are two types of challenges. Number one is these are the clinical challenges. So what are those clinical challenges? These include the high recurrence rate. So when we are going to operate upon these patients next time, we have to keep in mind that these hernias can again recur, and the recurrence is to the tune of around 27%. So that's why we need a proper planning before venturing into the repair of these hernias next time. Then these patients can develop a significant respiratory dysfunction post-surgery, because most of these hernias have loss of domain, and when we try to just put those contents back into the abdominal cavity, there occurs this significant respiratory dysfunction, which can lead to the abdominal compartment syndrome in the post-operative period. Then again, these patients, when repaired, most of these patients, their repair is done under tension, and they can present with chronic pain and mesh complications in the form of mesh infections, mesh exposure, and other things. So, from the patient's perspective, these complex ventral hernias, they severely diminish the quality of the life of these patients, and patients can develop psychological stress and other forms of stress at work. Then to sail safely through the through the ocean of the complex ventral hernias, what we need to do is we need to optimize all these patients pre-operatively. So what are the different types of optimizations we do in these patients? First of all, smoking. So smoking is a very high risk factor for recurrence. So what we need to do is we need to ask the patient to quit smoking at least a month before surgery and continue same in the post-operative period. After that, as we see in this part of the world, in these present days, obesity is a new challenge. So this challenge is again for the hernia surgeon as well. So most of these patients who are obese, they have very high recurrence rate. So obesity has to be taken care of either by medically or by surgically. So what we can do is we can put these patients on diet or medications, and if we think that these patients are not going to improve on diet and medicine alone, then we need to consider bariatric surgical procedures in these patients as well. Then diabetes, as all of you know, is a problem for all the surgical patients. So diabetes needs to be controlled properly, and goal has to be goal of HbA1c has to be between 7 to 8 for the successful repair of these patients. Then cirrhosis, again, is a very high risk factor for these patients. So cirrhosis needs to be controlled properly, and if any procedure like TIPS or paracentesis has to be done, so that should be done so that the patient gets optimized properly. Then nutrition, again, if a patient who has got complex ventral hernia is not nutritionally good enough, then his repair is going to fail. So nutrition has to be very good. The albumin has to be on higher side. It should be preferably more than 3.5. Then exercise is again very important in these patients. So exercise improves the quality of life of these patients. A 30-minute walk is recommended, and along with that, we have to give chest physiotherapy and deep breathing exercises to these patients so that the respiratory compliance increases. Then age. As age, you know that age you cannot optimize, but it has been seen that if you operate patients who are less than 60 years of age, the outcome is very good as compared to elderly patients. Then what are the essential diagnostic tools in these patients of complex ventral hernias? So first and the foremost is CT volumetry. So what is this CT volumetry? This is nothing but a plain or a contrast CT of the abdomen, wherein what we do, we take different measurements. We take measurements of the hernial sac, we take measurements of the abdominal cavity, and then we take certain ratios to confirm our findings. After that, we need to do a proper cardiorespiratory evaluation in these patients, and what is this loss of domain? So, as I told you, complex ventral hernias have their gut contents, abdominal contents outside the peritoneal cavity for most of their time. So till recently, there was no proper definition for loss of domain. But international Delphi consensus on the definition of loss of domain has been given, and which says that a ventral hernia which is large enough such that simple reduction in its contents and primary facial closure either cannot be achieved without additional reconstructive techniques or cannot be achieved without significant risk of raised intra-abdominal pressure. So how do we calculate this loss of domain? So loss of domain again is calculated on CT volumetry basis. What we do is we take the volume of the hernial sac, we take the volume of the abdominal cavity, and then we make certain ratios. The first one is the Sabag method. So Sabag method is nothing but it's the percentage ratio. So what we do is we take the volume of the hernial sac, we take volume of the whole of the peritoneal cavity. Peritoneal cavity means abdominal cavity plus the hernia sac volume. So we take the percentage of it, and any percentage greater than or equal to 20% is defined as loss of domain. And second one is the Tanaka method. So Tanaka method is again a ratio. It's simpler than the Sabag. It's not a percent. It's in the decimals. So we take simple ratio of the hernia sac volume and the abdominal cavity volume. So any ratio more than or equal to 0.25 is diagnosed as loss of domain. Then after optimizing the patient, we need to optimize the hernia as well. So what is optimization of the hernia? So the people who like to play chess, they know the importance of these two things in the chess. So in the same way, we have our botulinum toxin and we have our progressive pneumoperitoneum. So these two things are very important, and they play the role of knight and rook in our hernia optimization. So coming to botulinum toxin, as all of you know, it's nothing but a neurotoxin, and it prevents the release of acetylcholine. And after that, what it does, it causes the flaccid paralysis of the muscles. Then after it's given intramuscularly, its onset of action is within 2 to 3 days, and the peak occurs around 4 to 6 weeks. And the duration remains and wanes by around 5 to 6 months. And when it is given in a complex ventral hernia, a dose of usually 200 to 300 units is given in an average built person. Multiple sites are chosen as seen in the picture. This botulinum toxin is given on either side of the midline along the anterior axillary line at 3 spaces, in the hypochondrium, in the lumbar region, and in the iliac region. This drug has to be instilled into all of the muscle planes, the external oblique, internal oblique, and the transversus abdominis muscle. So this injection is done under the ultrasound guidance. You can see in the first picture, this is the ultrasound image of the muscles of the abdominal wall. So we can see the needle has been pushed into the layers of the muscles. In the video, you can see we are just doing it under real time, under the ultrasound guidance. The drug is being instilled into the different muscle layers, the internal, the transversus abdominis, internal oblique, and external oblique muscles at the predetermined sites. So you can see when we give Botox to these patients, we again go for CT scan after around 4 weeks. So this is the change which we see in these patients. In the first image, you can see the muscles are contracted, they are retracted, and they are thickened. And you can see the dimensions of the hernial sac. So it's around 12.6 centimeters. In the second image, which is post-Botox, after 4 to 6 weeks of giving Botox, we can see the results. The muscles are relaxed, they are elongated, and they are thinned out. And you can see what has happened to the hernial orifice. It has decreased from around 13 centimeters to 5.3 centimeters. So a significant difference in the hernia. Then this is a systemic review and a meta-analysis in using the Botox for these complex ventral hernia cases. On an average, they have found that they have gained around 3.18 centimeters of muscle on either side of the midline. Then one more thing, preoperative progressive pneumoperitoneum, or PPP. So what is this? This is nothing. It has been started way back in 1940s for ventral hernias. So what is done is that we take catheters, either it can be peritoneal dialysis catheter, or you can use simple central venous lines, and these lines are put into the abdominal cavity in the right upper or left hypochondria under ultrasound guidance, and we ensure that we have not punctured any viscera or gut. After we have confirmed it, what we do is we inject the ambient air into the peritoneal cavity of these patients having ventral hernias. So what it does, it increases the volume of the peritoneal cavity, and this procedure has to be done on a daily basis for around 2 weeks post this puncture. Then around daily air of around 500 to 1000 ml of ambient air has to be instilled, or it can be even more, and we have to see if patient tolerates even more air, we can inject more air in these patients. Then what does it do? It increases the abdominal cavity volume, it causes pneumatic adhesiolysis, it improves the diaphragmatic function, and it reduces the mesenteric edema. So one thing has to be kept in mind, that whenever we are doing this preoperative progressive pneumoperitoneum, since we are increasing the intra-abdominal pressure, so all these patients have to be put on thromboembolic prophylaxis. So this is a small video. We can see the catheter is in the right upper abdomen, and we are just doing this procedure in the ward only by using a 3-way stopcock. We are instilling ambient air with a 50 ml syringe into the abdominal cavity of this patient. So this is post PPP CT. You can see there is gas in the abdominal cavity. You can see what has happened to the abdominal cavity. The volume has increased, the adhesiolysis has been there, and the hernia has reduced. So these are the results after the PPP. So now what is the timeline? How do we do all these things? We start giving Botox around 4 to 6 weeks prior to the expected date of surgery. So minus 4 weeks we are giving Botox as per the recommended guidelines. Then minus 2 weeks. That means 2 weeks after giving Botox, we start progressive pneumoperitoneum in the patients who deserve it. And after that, we operate these patients. So these patients usually have large hernias with loss of domain. So most of the times it is the open procedures which are done in these patients, and the type of procedure which we do in these patients, they vary from simple Rave-Stoppa repair to posterior component separation techniques with transversus abdominis release, and sometimes peritoneal flap techniques. So in the first video you can see we are doing a transversus abdominis release in this patient. So we identified linea semilunaris, then we remain around 0.5 centimeters medial to the linea semilunaris and incise the posterior lamellae of the posterior lamellae of the tendon of the internal oblique muscle, and then we land up on the transversus muscle, and we divide this transversus muscle in the same line parallel to the linea semilunaris. By doing this maneuver, we enter into the pre-transversus plane, and we can go quite laterally into the abdominal cavity as far as we like. So you can see this is a completed TAR on one side, We have just divided the transversus abdominis muscle. We are in the pre-transversalis plane, and inferiorly we have to go into down the pelvis into the space of Bogros as well. So this thing is achieved after doing the TAR on either a unilateral or bilateral side. So we can close the posterior component in a relaxed fashion, in a tension-free manner. And after we have closed the posterior components, what we do is we put a big polypropylene mesh, which is medium weight, large pore, and the size is usually around 30 by 30 in our population. And we can always just adjust the size as per the body habitus of the patient. So since these patients of loss of domain, they have large pannus associated with the hernia. So most of these patients, they are subjected to abdominoplasty as well. So fluid-daily abdominoplasty we do frequently in these patients. We can see the large pannus has been resected and the repair has been done on the right side. So what is our experience at GMC Srinagar? We have started the study back in 2019 and we are still doing it, and we have got our preliminary results, and we have subjected these results. We have sent already a paper on these to the hernia journal, and that's under scrutiny right now. So what we did, we have operated around 679 patients of incisional hernias, total incisional hernias, I meant to say. Not LOD, total incisional hernias, and the simpler ones. And among them, we had 41 LOD hernias. 41 LOD hernias. And among these 41 LOD hernias, we excluded 12 patients because 7 had lateral hernias, which we did not include in our study. Then 4 did not complete the follow-up, and 1 patient declined the adjunct. That patient declined the Botox and the PPP. Then 29 of total patients of LOD were in our study, and then we took their indices, the Tanaka index. The Tanaka index in 16 patients was more than 0.25, and Tanaka in 13 patients was more than 0.35. So the patients who had more than 0.25, they were subjected to Botox only, and other patients who had more than 0.35, they were subjected to both the Botox as well as the PPP, preoperative stage. And after that, after 4 weeks, we operated these patients. So these were our results. Our operative time on an average was 236 minutes. Our blood loss on an average was 186 ml. We did not have any major intraoperative complication. Post-operative ventilation was usually in 3 patients. Post-operative ileus was present for around 32 hours in these patients. We removed the drains on an average on 5th post-operative day. The hospital stay was around 6 days for most of these patients, and the daily return to activity was around 17 days. Then coming to complications, we had hemorrhage in 1 patient. For that, we had to re-explore the patient on the same day. There was a slip ligature on the mesentery, and we had to re-explore that patient, and that patient did well. And then we had surgical site infection in 3 patients. We had basal atelectasis in 2 patients, which was a minor thing that was managed conservatively. We had minor seromas in 2 patients and chronic pain in 1 patient. So these are few case snippets. You can see this patient, she had loss of domain, a big ventral hernia which was complex. You can see she was operated multiple times. She had failed repairs multiple times, and then we subjected her to our protocol. You can see this is the CT scan. These are the axial cuts of the same patient. You can see most of the contents are outside the abdominal cavity. She has a definite LOD, and you can see the reduced abdominal cavity volume. These are the sagittal cuts of the same patient. You can see what is the condition. Then this is pre-op photograph, and that one is the post-operative photograph of the same patient. Then we have another patient. This patient again had loss of domain. We did pre-operative progressive pneumoperitoneum in this patient. We gave Botox to this patient, and you can see the results. This is a pre-operative photograph. And this is the post-operative condition of the patient. Again, few more patients, pre-operative, post-operative pictures you can compare. So now what are the key takeaways? So key takeaways are complex hernias are always challenging. Patience is the key. We have to be patient. We should not jump on doing surgeries in these patients. We have to optimize them properly. Then optimization is very necessary, and there are no clear-cut guidelines on the use of Botox and the PPP. There are no set protocols. Every institution follows its own protocol, and we need randomized trials to address this issue. Thank you very much.
Thank you very much, Dr. Samon. You have really given a good insight about this paper. I tell you honestly, some important things that I have noted in this study. I appreciate your efforts and I love you. You have been one of the nice postgraduate students. You are doing hernias and there are two complex ones. I appreciate you for that also. You are including the Botox and PPP for complex hernias. That's also appreciable. One thing I noted, the number of ventral hernias too high. We are all teachers here. We are teachers in surgery. That means there is some problem with the closing techniques of the abdominal wall closures once primary operations are being done. And I think major problem is with the seniors who do not supervise the juniors. They leave. See, I tell you honestly, I always think about these things. Then our gynecologist colleagues, you must have seen that majority of ventral hernias are intraumbilical, and that too very large ones. They do not undergo surgery. They usually have multiple pregnancies also. So I think seniors should introspect that once you give open or closing an abdomen, they have to supervise these people, because I think this is a preventable thing. Only in those patients where you have infection, you have fistulas, you have complex surgeries or recurrent surgeries, the possibility of complex hernias arises. Otherwise, majority of these people, these patients are preventable. One more thing I just want to tell you about here. We are also dealing lot many complex hernias. The reason is that these are being referred to our place because of the ventilator support, multidisciplinary management. I even appreciate the plastic surgery colleagues here, Dr. Mushtaq and Dr. Masood, who have done a commendable job in managing these raw areas. In fact, this is one of the best treatments for raw areas in abdomen also. So many patients who have been able to revive, who have been able to do stage procedures. In complex hernias also, we try to do sometimes stage procedures that help you a lot. It's not necessary that you do a primary repair one at the same time. You can do staging repairs and then achieve the best possible. And then using meshes in these, again it is a challenge. What type of mesh, what will be the cost, how many defects will be there, how many release incisions you will have, how much drainage you will have, seromorph formations, and then post-op morbidities, asterities, several comorbidities like diabetes, pulmonary, renal, so many complex. It's really, really challenging. It's not that easy. And then introduction of laparoscopy. Again, that's another challenge. I appreciate your efforts also. You have been also doing it in some areas. You would like to have any person want to have any questions?
As you told, the job of the seniors, we encounter many patients and our casualties as peritonitis. So my experience has been, in any patient who is a case of peritonitis, we do in the emergency, we should put a drain in the subperitoneal. That reduces the chances of hernia almost completely. But there are fast-track surgeries. I do not challenge that, but putting a drain in an infected patient is very important. That reduces the chances of hernia. Otherwise, not.
usual excellent talk and excellent work. Only I have one query. You do not eat up RS in these patients with TAR, laparoscopy. You have any experience?
Complex ventral hernias with loss of domain. So these are complex ventral hernias with loss of domain with a large penis. So laparoscopy I don't think will be a justice to these patients. But definitely they have results have been better, but we always prefer to do them by an open approach because we needed transverse abdominal sleeves, we needed sometimes peritoneal flaps and other things. We needed to excise the redundant tissues.
You might have to add up an abdominoplasty.
Exactly.
Here you cannot have an approach.
So you cannot do those things by
That is one
laparoscopy.
patient that result was from 12.5 to 5 point something.
Yes.
5 point something, you should have tried it. What is the problem here?
But that patient had a good big penis, loss of a lot of redundant skin and other things. So you can do justice.
Any comment or deliberation from the August gathering? Anyone, please? Yes, please.
Regarding the management of this complex hernias, as Dr. Samun was rightly saying that those patients who have loss of domain and who have a large panel, this is just a comment for Professor Nazeer Gawani's question. These patients have a lot of skin infections also. They are troubled with intertrigo, they are troubled with a lot of dermatitis. And apart from having this very large hernia, which is aesthetically very disfiguring and displeasing for them. Simultaneously, they want to solve the problem of these skin infections. That is why we usually offer them abdominoplasty also, and they are very happy with that open approach.
Once you have large hernias, they are almost always associated with decubitus ulcers.
Yes.
In fact, that is the reason that they go for surgery.
Concluding remarks.
Thank you, Dr. Samun. It was a nice IT presentation. Thank you very much.
Thank you, sir. May I request now Professor Dr. Nisar Ahmed Wani, sir, former Professor, Department of Minimal Access and General Surgery, GMC Srinagar, to please come on the stage, sir, for felicitation. I would like to request Dr. Abdul Hamid Samun, sir, to please come on the stage and receive your memento. I would like to request Professor Dr. Mohammad Shafi, sir, to please come on the stage. I would like to request Professor Dr. Ijaz Ahmed Malik, sir, to please come on the stage.
I'm really indebted to Professor Iqbal and his team, GMC team, for giving us the opportunity and inviting us to these forums. I really appreciate your efforts there and congratulate you. Thank you.
Thank you, sir. I would like to request Professor Nazeer Ahmed Wani, sir, to please come on the stage. The presence of our patron has graced this academic gathering. I request Professor Ifat Hassan Shah Ma'am, Principal, Dean, Government Medical College, Srinagar, to kindly bless this ritual by Islam.
A very good evening to everyone. Professor Parvez Shah, ex-Principal Dean, Government Medical College, Srinagar, ex-heads of the Department of Surgery, GMC Srinagar, heads of the Department of GMC Srinagar, and various heads of departments from SKIMS, GMC Baramulla, GMC Anantnag, distinguished faculty member, ladies and gentlemen. It's a privilege to be here amongst you and welcome you all once again as a patron of this conference organized by the Department of General and Minimal Access Surgery, Government Medical College, Srinagar. The theme of today's conference is very relevant beyond closure. As we all know, surgical wounds and complex hernia are difficult to treat. So it's important that deliberations are done to tackle these vexed problems. And I'm sure whatever deliberation must have been taken place in this CME today would go a long way in clearing the doubts and also think of a better approach to for these ticklish problems. Today's CME is special because today the CME has been held in memory of our teachers who have been the stalwarts of surgery, Government Medical College, Srinagar. Professor Pirzada Abdul-Rashid Saab, Professor Mohammad Shafi Nizgar Saab, and Professor Dr. Said Ashik Hussain Naqshbandi Saab. They were our teachers, and we still remember how they would take the rounds. They have been I was an undergraduate student once they were in the Department of Surgery, and we have seen them, Dr. Ashik Saab, as our principal also. We are grateful to the family members of Professor Shafi Saab and Professor Ashik Saab who have joined us today, and for the countless students whom they have taught, their memories are etched in their mind. But for the postgraduate students whom they have shaped up into perfect surgeons is something that they have earned in their lifetime. And it's in their memory that this CME has been organized. I'm especially grateful and must compliment our Department of Surgery, Government Medical College, Srinagar, who took the lead in this initiative, and the organizing chairman, Professor Iqbal Saab, organizing secretary, Professor Mushtaq, the joint organizing secretary, and the co-organizing secretary. They need a big round of applause. Their efforts have made this CME see the light of day, and I'm sure all of you who are participating in this conference must have enjoyed the scientific deliberations. I once again welcome you, and I'm thankful that you came here for this CME organized by the Department of Surgery, Government Medical College, Srinagar. Thank you.
Thank you so much, ma'am. I would like to request Professor Dr. Iqbal Said sir to please come on the stage. I would like to request Professor Dr. Ifat Hassan Shah ma'am to please come on the stage to receive felicitation. I would like to request Dr. Parvez Shah sir, former Principal Dean, Government Medical College, Srinagar, to please come on the stage and receive felicitation.
dear colleagues, students, Professor Iqbal Singh, I am highly grateful to Department of Medical Access Surgery, Government Medical College, Srinagar, for giving me an opportunity to come to this program and receive felicitation from Department of Surgery, GMC Srinagar. I am highly indebted to this department and its organizers for this benevolent event. I am highly grateful to all of you. And at the end, I would like to thank Professor Munir Khan Sahab for his initiation, for being pioneer in minimal access surgery in our valley. And I am one of the first patients of Professor Khan Sahab who has undergone lab poly with his hands. Thank you, sir.
Thank you so much. I would like to request Professor Dr. Ifat Hassan Shah ma'am to please come on the stage. I would like to request Dr. Andeep ma'am, a medical superintendent, Medical College, Srinagar, to receive the qualification.
I want a big round of applause with heart for Dr. Ami, because she is instrumental in maintaining our hospital, which is overflowing with patients, but still she smiles and she listens to my rants and my department rants. Thank you very much, ma'am. This is a small token of appreciation for you. Now I'll request Dr. Arshad to please come here. And for his father, there is a memento. Obviously, he will be collecting it from Madam.
Thank you very much, Professor Iqbal. It's really heartening to be here, that you conducted this CSP in fond memory of our esteemed teachers who have left us, and we pray that we pray for their eternal solace in the of life.
Now I would like to request Dr. Ifra and Dr. Yasir to please come onto the stage. I have already explained my inner feelings regarding Professor Saeed Ashif Hussain sir. Madam will provide a memento. Leo.
Assalamu alaikum. There are no words to express my emotions at this moment, but I would definitely like to express my heartfelt gratitude to the Postgraduate Department of Surgery for inviting us among all of you. I know most of you have been associated with my father either as a friend, a colleague, or a student. I would like to express my heartfelt thanks to the principal, Government Medical College, Srinagar, Dr. Ifat ma'am, and especially Professor Parvez Ahmed Shah, with whom my father was deeply associated. I am thankful to all of you. Thank you.
Thank you. Thank you, ma'am. Now, sir, if any senior would like to say a few words about our Professor Munir sir, regarding the three of, they might have been your teachers and then they were your colleagues.
At the outset, I thank Professor Iqbal for organizing the CMU and remembering the teachers. So this is in the last 15 years, the first CME rather, for our teachers, in the memory of our teachers. Well, it was my privilege to work with Professor Rashid Shah, and he was, as you all know, he was a dying, very good surgeon, and those days it was mainly open surgery, things have changed, but he was an excellent open surgery trained in UK. And then I remember one of the incidents when I was working as his registrar, and in emergency we did, I was first working with Madam Professor Mahmood Khan, and then it was vacation and I was transferred there. So the first, there was a splenectomy which came, and we did it with the right para median incision, because we didn't have the CT at that point of time. And the diagnosis was only on the table at that time. And we managed the splenectomy with the vertical right. We did not, otherwise doing a T was a fashion those days. And the next day when the round, we told him, the registrar, PGI. So they told him that they have done the splenectomy. He said, he was a bit surprised, but he appreciated it. Regarding Dr. Misgar Saab, I've been working with him. I've been in his department. I owe a lot to him. And I remember certain thing I should tell you. During the thick of the presidency, some people came, as usual, they used to come off and on. Our hospital was a den, and they wanted me to take me along. But Dr. Misgar Saab, he accompanied me with the person, and wherever they took us, then finally he negotiated, and we were back home. But at that point of time, nobody was going with anybody, and he came with all those 2-3 meters with the pistols and all those things. But I appreciate it. God bless him. And regarding Dr. Ashik Saab, he has been my senior colleague. We have been together for a very long time. And he came from Vellore, where he did his MCH in CTVS, and then, well, I came from All India at that time. He was senior to me a couple of years. We had a very good cordial relations, and we enjoyed quite a bit. If you want to know incidents, the admissions which those days we used to take ad hoc, the HOD used to take ad hoc. So we had an exam. Dr. Ashik said, you select the people for ad hoc. I think many of them are professors here at the moment. Those ad hocs so there was a written test. I said, okay, a written test. And in his chamber only, with all the consultants over there, and then the results, it took about 5 minutes only because the key was there. And it was handed over to Ashik Saab immediately. Then came pressures from here, as usual. But Ashik Saab put his foot down. He said, I can't help you. You talk to me. At that time I was young and I was much more rigid. You become soft once you age. And he did not, I appreciate, he did not yield to any pressure. He was a central minister at that time, calling him repeatedly, and also saying we will give you great funds, 10 lakhs. It was quite a bit of money at that time, giving it to the department, but he put his foot down and the results remain the same. Thank you.
Now I'll request Dr. Nisar sir for a few words. See, we meet very rarely, and our teachers are here. To listen to them regarding their colleagues is an experience in itself.
I have no Professor Sadir because the first time I see that there is a CME in the name of our Professor Fell we have lost. I had a chance of working with all of them. Dr. Shir Saab, Dr. Misgar Saab, and Dr. Ashik Saab. Dr. Rashid Saab, the most gentle and human person I've seen in my life. Still human being, good human being, a great asset, and a very good surgeon because I had a chance to work with him for a short time. How nicely he was doing, nicely worked on this. That's all. Dr. Mirza Sahab had been associated as a registrar, as a consultant also. For a long time, he has always treated me just like Speaker Mehta. Lord bless him with the fellows. Ashok Sahab I know from my childhood, and he has been a great human being, a very nice, efficient doctor, efficient surgeon, no doubt about it. And I had associated with him in Cancer Society of Kashmir for the last 25 years. And we have worked together for the setting up of a cancer hospital in Kashmir. Most probably, it is almost now complete and we will be inaugurating it most probably in next year. But he is not here. We lost him just before that. Thank you very much, Dr. Akbar Sahab, for a wonderful program like this in honor of you. Thank you.
Professor Ijaz. Professor Ijaz is one of our colleagues, madams and my colleague.
Assalamu alaikum, everybody. I have been closely working as a junior fellow with Professor P. Zada Rashid as a house surgeon and with Professor M.S. Mirza Sahab also. Let me tell you about Professor P. Zada Rashid, a tall, towering personality with lot of humility, and he would always teach us like his own sons. And I remember I was a junior right house surgeon in Ward 12 and 15 at that time, and we were 4 house surgeons, 3 of us are in UK this time, I am here now, and Professor Mufti Mahmood was our junior postgraduate, and Inam Saab was the senior postgraduate, Dr. Sardur Saab was our lecturer, and he would start the round. I had first 7 beds allotted in Ward 12. He would start the questions from house surgeon. After completing the history and examination, then he would start bombarding with the questions. I remember once that he started with the questions and I was preparing. It took half an hour. I was answering some questions, I could not answer some. After that, he remembered, I have got hold of this only one guy. He told somebody, because I was tall, they were shorter than me. So he got the second one from backside for house surgeon and started asking him the question. And I still remember he showed us varicose veins. And typically he told us, this bag of firmness, you palpate. And I still remember, and then he would go take us to the X-ray department where our X-rays will be in a locker and then discuss them one by one in his room. And one beauty about that person was that he would always, at the end of ward rounds, he would make a round of the washrooms. Always see whether the washroom, which most of the labs is fine. Then our Professor Misgar Saab, I have worked as an assistant surgeon after completing house job in surgery and orthopedic because of lack of staff. Were again taking as assistant surgeons. And the beauty I saw in him, he was a very calm and cool surgeon and a very perfect surgeon. My first encounter was to watch him a recurrent inguinal hernia. You know, in inguinal hernia, there's mesh and recurrence, so you cannot find any anatomy. It was so beautifully tackled by him that made me to inspire to take the surgery as an art in for future. Then, when I joined as postgraduate, he was the head of the department. That time, I went to him, said I have joined as a postgraduate. He told me, okay, you go to Dr. Munir Khan, he's your guide. When I went to Khan Saab, said, you are my guide, I'm not told. He told me, I give you 7 days. You decide, you want to work with me or not. I did not know what he meant. I told him, sir, I want to work with you. But I didn't know what was in his mind, which actually he was a very energetic and very fast person. He wanted a person who would run after him like he runs this time also. So if I have not done this, if I have not learned the art of surgery from him, at least I have learned how to move fast, which I am also learning. Thank you very much.
I think it's important that Professor Mufti Saab says few words because he has been associated with almost all 3 of them. Professor Mufti and me are colleagues. He's my senior, but we are still colleagues.
Actually, I have been very fortunate to have worked with all 3 of them. I was postgraduate in '91 with Professor Rashid Saab. And when I was a registrar with Dr. Ashik Saab, I was junior consultant and registrar with Professor Misgar Saab. All were great teachers. They had their own individual virtues. They had their own style of communication, their approach to the patients, and their surgical skills, of course. The common thing about them was dedication. It was peak of militancy. There was no accountability. Students were coming. Teachers, it was their discretion whether they would hold classes or not. And nobody would take them to task because everybody was so overworked that academics really went to the background. And I saw the three of them. They had their roster in place, but I saw them following the roster judiciously. Whatever would be happening outside. I remember Rashid Saab in Ward 15. He would take the class. He had a small booklet. I happened to be his PG, and he would keep on revising his class in that booklet. Once he forgot it in his locker in the car, and he said, "Get me my booklet." I saw it as inscribed in very legible handwriting, and he would just go through the points. And his lectures were not only academics. His lectures were motivated to the student that, look here, lecture is okay, but see, what is your future? Your future is only there once you are dedicated to your patients. He would sort of evoke those feelings among the students. And that was the great thing about the teacher. And Misgar Saab, he was very hard work, energetic. He would start his day, I think, soon after Fajr Namaz, and he would end up late after Isha. He would work tirelessly in the hospital, outside the hospital, and he had his goals, of course. He wanted to build up a hospital, and he worked for it. He worked energetically for it, and he did what he wanted. He dreamt about that hospital, and he got it. And he raised some standards in the department. He maintained cordiality among the faculty, among the juniors. He was their friend. He would have frequent small feasts within the hospital in his room, call everybody around. So it was just like a small family. And that was a good thing about him. Professor Rashid Saab, he was kind of reserved. He had his own style of working. And he would not mix usually with students or his juniors, but he had his own class. One episode I remember, I think Dr. Sardu Saab was here. He was his registrar, I was PG. His mother-in-law was taken ill, and she was brought to the hospital. And he immediately took her to Dr. Lagman's ward. Dr. Lagman advised an X-ray chest, and she had probably pneumonia. And Rashid Saab had a look at that X-ray, and Lagman Saab said she has pneumonia, she needs to be admitted. 2 days down the line, we had our OPD. Dr. Sardu was registrar, just sitting opposite to him. He started coughing. And he told him, you get up and get your X-ray test. So he said, you take care of the diary till he comes with the X-ray. So obviously, he advised him X-ray, so he had to show him the X-ray. So he came with the wet film and showed it to Rashid Saab. And he told him, it's actually me in Hashgum. He did not tell him the diagnosis. Really, just me in Hashgum, you please go home. So that was it. That was Rashid Saab. Ashik Saab was a very disciplined person. His war rounds was worth watching. His style of examining patients, his style of asking questions from the students, and he had his own defined style. And as a surgeon, I've seen him. He was so meticulous with those long, thin fingers. I've seen him, his dissections.
and they were really worth recording. We didn't have recording systems over there, but it was a great section, clear concept of anatomy, and it was a real good session. And what to say, we will always miss them, and they were a treasure for the entire surgical fraternity, for Medical College, Srinagar, and for the community at large. Allah bless them in the highest pinnacles of Jannah. That's my earnest prayer for all of them. Thank you.
Thank you. I would kindly request Principal Ma'am, Professor Dr. Ifat Hassan Shah Ma'am, to kindly felicitate our organizing committee. I would like Iqbal sir to receive the memento as an organizing chairman of this CME. Thank you, sir. I would like to invite Professor Dr. Mushtaq Ahmed Meet, sir, Organizing Secretary of this academic program. Thank you, sir. I would like to request Dr. Tahir Salim Khan, sir, Joint Organizing Secretary, to please come on the stage. Thank you, sir. I would like to invite Dr. Hanif Mohammed Dar, sir, Joint Organizing Secretary, to please come on the stage. Thank you, sir. I would like to invite our board member, Dr. Abhad Mueed, sir, to please come on the stage.
Request Principal Ma'am to felicitate our hard-working registrar, Dr. Samra. She has really worked hard for this CM. Thank
Now I would request Professor Dr. Iqbal Salim Meet, sir, to please come on the stage for felicitation of our pharmaceuticals. I would request Mr. Mukesh Sehgal, Vice President Santor, to please come on the stage. Thank you, sir. I would request Mr. S.N. Rizvi, sir, to please come on the stage. Thank you, sir. I would request Mr. Nelson to please come on the stage. Thank you so much, sir. Thank you, sir. May I now request Dr. Tahir Salim Khan, sir, Joint Organizing Secretary, to the podium to propose the vote of thanks.
Assalamualaikum, and thank you for coming and raising this occasion. I know that all of you will be hungry and waiting for the dinner eagerly. I'll take 2 minutes. For delivering this vote of thanks. First of all, I would at outset like to thank Almighty Allah who has given us this opportunity to be here assembled with everybody, with our seniors, with our peers After that, I would like to thank Ma'am as patron who has spent her time, really busy schedule for her, and out of that she has spent these moments with us. We are really honored and we are really thankful. And so we are very thankful to you, sir, that you have with us a long time. I believe you are here. Thank you, sir, for being with us. I deeply appreciate the efforts of our organizing chairman and head, Abbas Salim, sir, who has been always our inspiration in the department, right from the table and scale with the academic events, and he is really after us to conduct these academic events every summer. And with his vision and with his inspiration, we are able to do these events. I thank you and I appreciate it. After that, I appreciate my colleagues and my co-organizing committee members who have put tireless efforts in this event in the last 1 week. This has come at a very short notice to the organizing committee, this event, and they have all done well, and this event has been really a success because of their efforts. Dr. Mueed, Dr. Sada, really we appreciate your efforts. Then our sponsors have been very kind and gracious to sponsor this occasion and blend the academics with the industry so that we can have these events in the future also. We are really thankful to you, Dr. Mukesh, Mr. Nelson, and Mr. Mukesh Sahgal. We are really thankful to you. Last but not the least, I am seeing all my previous teachers who have taught me surgery, who have given me scalpel in my hand. Professor Munir Khan, Professor Sabru Saab, Professor Shafi Saab, they have been all my teachers when I was a postgraduate and when I was a registrar. I have become a surgeon while seeing them. I was very much envious with Professor Munir Saab, with his attire, as everybody is. And my immediate teacher has been my registrar, I should say. Please give a big applause for him. Dr. Arshid Mirza. He has been my registrar. He has taught me emergency surgery in the institution, and I owe him a lot. Thank you, Dr. Arshid. And I lastly thank all the participants, and I thank all those whom I have not been able to mention. Please forgive me for that. And I welcome you all to have a dinner, very good dinner which we have kept for you. Thank you.